Hello, everybody, and thank you so much for making time to join us for another one of our Meet the Specialist sessions. Today, we have the very, very lovely Dr. David Johnson, neurosurgeon, and he's a little bit different to your average neurosurgeon. I know that you will find this presentation really interesting. This is just a quick intro as to what he does, what he is, and how he can be of value to you in your medico-legal work through MAG. So thank you so much for making time for us as well, Dr. Johnson. Over to you.
Yeah, good afternoon, everyone. How are you going? Hope you're having a wonderful day. Yes, as Michelle said, David Johnson's my name, neurosurgeon. Been in private practice since 2007. Did my time in public practice as well. I trained at all the tertiary hospitals around Queensland and worked for a long time at the Princess Alexandra Hospital and also the Royal.
David, sorry, can I get you to click unmute? I tried to mute somebody and I accidentally muted you.
Can you hear me now?
My apologies.
Did you, yes, was it only just unmuted there, Michelle, or the whole thing?
Yeah, just then.
Oh, just then, okay.
Yeah, just then.
Yeah, so my private practice is primarily a spine pain management practice, which of course includes surgery 1 or 2 days a week. My objective as a surgeon is really to try to prevent people from needing surgery. It's a bit ironic. I'm trained to operate on people's spine, but I see it as my role to try to help people not have surgery. That's really, no one wants to have surgery. So we're not really doing our job properly if we're just saying, okay, you need an operation, come on, sign here and we'll go and do your surgery. Yeah, the fact is that, day of consulting, 15 odd patients, you probably only see 1 or 2 patients that truly have structural compromise that requires surgery. And so what do you do with that other 13? And what's the most important information that you're going to convey to the 2 people that do need the surgery? The most important information that I see is that, what have you done wrong in relation to your spine that has pushed you towards this difficult decision and, frankly, frightening decision of having to consider spine surgery. So my role is to try to educate the patient along those lines. And then, of course, there's, 95% of patients who you see and you assess their structural spinal integrity and you go, there is no place for spine surgery on you. But I understand that you still have, chronic pain and disability. So you've come to see me for a reason. Now I need to give you a solution that is going to resolve your chronic pain, because you've come to see a specialist, and normally that's 5-10 years down the track of trying to do things for your chronic pain that have failed. Okay, my patients are tertiary referral patients. They're not seeing a neurosurgeon in the first week of their pain. They're seeing the neurosurgeon 10 years down the track, and it's not acceptable for me to just say, well, look, you don't need surgery, go back to your GP, because the GP sent them to you because they didn't know what to do with them. And I can guarantee you that the GPs have already sent them to the physio, they've done hydrotherapy, they've done Pilates, they've done chiropractic therapy, they've done exercise physiology. A lot of them are financially ruined. They have psychological disturbances. They have problems associated with drug dependency, and then the side effects of that, right? I see an emerging problem now where the policymakers and guideline makers and authorities are sort of saying, well, now I know you're in chronic pain, but we've got an opioid crisis. So we're going to start making it even harder for you to get your symptom-based pain medication. So that's becoming a big problem. And the opioid crisis, the term opioid crisis, I think it's not really. It's just a misguided term. It's like, yes, consumption of opioids and dependency of opioids is very bad, but no one's asking the question, why are we having the opioid crisis? Why is our musculoskeletal and spine pain so prevalent in our society that is making people need to consume opioids? I'm sure no one wants to consume opioids. I'm sure no one wants to have to, sit in a doctor's waiting room and go back in there for their scripts every 2 to 3 weeks because they can only get 20 tablets at a time. No one wants to do that. But yet the industry is quite poor at taking accountability for why we have a musculoskeletal pain epidemic. And of the musculoskeletal system, a huge proportion of that is back pain. A huge proportion of that is back pain, and I'm sure everyone listening and on the Zoom knows someone or has experienced back pain themselves. So that's why I'm here presenting from my rehabilitation centre. This is the sidearm of my surgical practice, if not the more important arm of my surgical practice. This is where I refer all of my back pain and spine pain patients to, because I simply know that they cannot just go back to a service that they've been failing with for 5 to 10 years. There is no point me sending them back to the hydrotherapy pool because that's already failed. So what we have here is what I refer to as a functional movement training centre. Okay, so if you look up the functional movement training centre online, you'll be able to see a little bit more about it. And why that's relevant in the medico-legal field, I'm gathering that people listening are working in the medico-legal industry. Why that's relevant in the medico-legal industry is that one day a week I do medico-legal work. I have a dedicated medico-legal day where I assess patients and provide reports. And the recurring theme that I see is that our mechanism and our system for assessing injury relies on the diagnosis-related estimates, the DRE system of the AMA5 and the Guides to Evaluation of Permanent Impairment. And it is almost wholeheartedly focused on structural compromise. Okay, so independent medical assessor could review a patient who is taking endone, Taj and anti-inflammatories, cannot work because of pain and disability, and of course, had an injury at some point in time. They're now 6 months down the track. They've had all of the interventions, that insurers provide to injured people. And they will determine an impairment of 0%. Okay. I'm sure you can all relate to that. That is the norm rather than the exception for most. They will describe things on the imaging element of the report as degenerative changes. These are degenerative changes. This is lumbar spondylosis. These are normal age-related changes. So there's a massive discrepancy or a massive disconnect between the actual medico-legal report and the patient in front of you. And that's where I start to try to explain to insurers and patients the disability and pain that people suffer from is a combination and an interrelationship between structural changes and functional changes. And a lot of the reporting that I read and IMEs, and from what patients tell me, there is a massive ignorance to functional disturbances. Okay, functional disturbances. And what I mean by functional disturbances is it's irrelevant what the MRI may look like from a structural perspective, because an MRI is just a snapshot. It's not a functional scan, it's a structural scan. But when you actually assess a patient and you look at their function, which is also able to be referred to as their proficiency or their musculoskeletal skill of movement of their lumbopelvic spine. When you understand that, you can very clearly see massive functional disturbances in their biomechanics. And it's those massive functional disturbances in their biomechanics that continue to drive their pain. And if I then ask a patient, okay, so what have you done over the last 5 years in order to try to improve your pain? Everything that comes back is a structural intervention. Okay, so I've taken injections, I've taken pain medication, I've rested, I've stopped working, I've stopped gardening, I've stopped, my sports and leisure. I've had surgery. These are all symptom-based structural interventions, and if you do not address cause-based functional problems, you will continue to have a high level of pain and disability. And so the DRE system may be very low. Okay, so I will put on my reports that they fall into DRE 1 or 2, and the impairment rating is as defined by AMA. However, there are massive functional disturbances, which equates to massive levels of persisting pain and disability that requires this, and this treatment, which may still result in a very significant amount of financial compensation to achieve those objectives, so that you can actually resolve the problem, and so that patients or clients receive adequate compensation. It's not okay to just say, I know you can't work, I know you can't even get out of bed with the help, but you've got 0% impairment. I'm sorry. That doesn't sit well with me. And you could turn around and say, well, they're just malingerers. They just don't like their job and they just never want to go back to work. I think that is just a reflection of you not thinking critically enough. If you don't take accountability and you can't unravel the complex puzzle, it's not a failing on the patient, it's a failing on you as a clinician or a medico-legal advisor or reporter.
David, thank you. That's really insightful. I have a question from somebody who wasn't able to join us today, but I want to put out to everyone else who's listened. Does anyone have a question that they would like to ask of Dr. Johnson? You can unmute yourself if you wish to do that, or you can type it into the chat. There we go. Renee? No? Okay. The question that I have is from someone who is an insurer's case manager, and they're talking about long tail claims. So people who've been going through the process for a very, very long time. And their observation is that these people, as you rightly commented, have been on opioids for long periods of time, and often on combinations of different opioids, some of which have an impact on further things like, dry mouth and the resultant dental complications that occur, skin allergies and changes as the result of long-term use of opioids, stomach issues as well, in terms of irritation of the lining of the stomach and intestinal things. But the other thing that she commented on is significant amount of weight gain. So the longer that goes, if the person is dependent on opioids, but also has gained significant weight, that means surely that their pain is going to intensify because their body is having to move around a greater weight of stuff anchored by an unstable spine. Would you talk to the timeliness or to the importance of greater speed when dealing with spinal issues?
Well, absolutely. The quicker that you can intervene with effective therapies, logically and common sense tells us that you're going to get better outcomes, and that's one of the problems with the workers' comp system, is it typically takes a long time for patients to navigate the system. And sometimes people don't even register their claims for 6 months after an injury, yes, there becomes secondary problems that develop as time goes on, such as the weight gain and the drug dependency and all those other side effects that come with it. So it becomes more challenging, just with layer upon layer of things that need to be done. But in terms of eventually getting people back on track, you still have to address the functional proficiency relating to the spinal joints, because the most significant factor that determines the health of a joint is whether it's stable or not. And we were just talking about that before with Michelle before we started. Stability, everyone understands the word stability. Think about it like riding a bicycle. The very first time we jumped on a bicycle at the age of 5 or something, we were wobbling around all over the place, and we probably fell over because we were unstable. Okay, but once you've done it a few times, you're very stable on the bike, and you start wanting to go faster and faster, and you're stable because you're safe. Now, bring that into the realm of spinal joints, which are really just bones stacked up on top of each other with a little shock absorber in the middle that we call the lumbar disc, or the intervertebral disc. Now, if that joint is unstable, it's going to acquire progressive and accumulative structural changes that then activate nociception and activate inflammation, which causes pain and disability. So whatever the intervention that is delivered from day one after an injury, after you start to feel pain in your back, you have to address stability in conjunction with controlling the symptoms. Yes, it's okay to take a bit of Nurofen or Panadol, or put a hot water bottle on your back and have a day off work. But if that's the only thing you do, which is kind of what people do when they get injured, if that's the only thing they do and no one talks to them about how to restore stability and maintain stability, the pain will not go away, or it will go away temporarily and it'll be back again in 6 months' time. Right. And that's kind of the picture that people get when they fail return to work programs. So they get injured, they go through these symptom-based interventions for a while, they downgrade their duties, or they stop working altogether, and then they make contact with their claim manager. Yes, I'm feeling better. I'm just sitting around watching TV all day. Okay, you're feeling better, go back to work. So they go back to work. The first day back at work, bang, their pain comes straight back again, and they go home. And that is a classic example of intervention that has only addressed symptoms, has ignored causation, and has ignored stability. The patient has not reacquired the ability to express spinal stability. That's really, really important.
Yeah.
Sorry.
No, I was going to say that probably follows onto a question that we have popped up here in the chat. When is spinal surgery indicated, especially requests for multi-level spinal fusions of the neck and lumbar spine?
Okay, let's break that question down. What is the purpose of a multi-level spinal fusion? Okay, what is the purpose of that? The purpose of a spinal fusion is to surgically implant stability. Okay, when we put bolts into the spine and we span the disc, okay, so say it's an L4-5 or L5-S1 or multi-level L4-5-S1. So there's some surgeons that love long segment fusions because they think the more segments they fuse, the more stability they can get. So surgical fusion has the same goal of creating spinal stability. Now, that is only required if the patient cannot regain natural stability. Okay. Hopefully everyone listening has natural stability in their back right now. When we finish this podcast and we stand up and we walk to get a cup of tea or something, we have stability. If you are in chronic pain and the therapy that you receive does not restore that natural spinal stability, that is when you would be deemed to potentially benefit from spinal fusion. But the problem is that there's a lot of people that have done years of rehab and they still have not restored their stability, because the rehab is not actually goal-oriented towards creating spinal stability. Core strengthening, for example, I'm sure you've all heard of core strengthening. Core strengthening makes certain muscles stronger, but it has a very low potency ability to restore the function of a very important muscle in the spine called a multifidus muscle. Okay, so the multifidus muscle is very deep, right down in the deepest layers of the spine, and they're like little finger muscles. They're like little finger muscles that are like this. And say my forearm's the spine. The multifidus muscle are like little tiny finger muscles. You can Google multifidus, multifidus. Those muscles are deep down. And what those muscles do, if I contract the multifidus muscles, they don't actually make you move, but they grip around the spinal joints and they create stability, right?
Mm-hmm.
But a lot of this core strengthening programs, including Pilates, including exercise physiology, planking, crunches, all of the stuff that you could think of, swimming, hydrotherapy, even a lot of gym-based exercises, they do not restore, they do not make the multifidus muscle recondition. There's a big difference between core mobilizers and core stabilizers. Okay, so if you do a lot of core strengthening activity and you only make the core mobilizers stronger, and the therapist goes, "Oh, fantastic, you've got a six-pack now." Guess what? The core stabilizers can still be very flaky, in which case you are still unstable and you will not recover from your back.
Right. Wow. And the next one here says, what percentage of your program participants return to work? I'm assuming this may not be the goal for some people in their recovery.
So I keep pain and disability scores on all of my patients. So I want to know that I want to know what my outcomes are. So we've studied this over the last since 2015. We started collecting data. We've been a lot more precise with data collection over the last 4 or 5 years. Remembering that these are patients that are biased to poor outcomes because they're tertiary referral. So our average ODI, our average Oswestry Disability Index is actually very high. It's in the moderate to severe range, okay, as opposed to someone who just walks in off the street and they just got a bit of a niggly back. Most of my patients who do functional rehabilitation have very high pain and disability. And we know that in 6 weeks of functional movement biomechanical proficiency training, we can reduce ODIs by 50% on average. So there's a 50% reduction in ODI. And then when it comes, the question was specifically about returning to work. Once we get a patient out of pain, we still need to increase capacity to meet the demands of their work, because capacity and demand have to be in check. You can't just go, okay, I've got pain, I've recovered, I'm out of pain, this is my capacity, but I'm a bricklayer. The demand of bricklaying is up here. They now need another 3 months to be able to meet the demand of bricklaying. Okay, but they improve their functional capacity on the foundation of having established stability first. Okay, if you don't first establish stability, there is no way that you can push their capacity up to the level of their previous work. Okay, so often it's a two-phased approach. Build stability, make them understand stability, make them understand movement proficiency, and then, oh, what do? You're a teacher. Oh, that's very low demand. You can go back to work. Oh, what do? I'm a plumber. I'm a formwork carpenter or something like that. That's tough. I've got to build your capacity up now. So that's when I will say to work cover, right, we've got pain under control, we've got movement under control. Let's now build capacity so that he doesn't go back to work and re-injure himself on day one.
Thank you. We've got a couple more questions. Are you willing to answer them, or do you want to wrap up and I can answer them in an email?
No,
Okay.
I want to understand this functional.
Cool. So one of the questions is, how do you activate the multifidus muscles?
Okay, so firstly, you have when we think about muscles, let's use an example of your biceps, right? Everyone kind of knows what the biceps does. Okay, so if I do that, I've activated the biceps muscle, biceps brachii. There's a couple of other elbow flexors, brachialis and brachioradialis. Okay, so we know what that does. What you have to understand, the reason we have a multifidus is to hold the spine in a neutral position. Okay, so that's what the multifidus does. And so it holds the spine in lumbar neutral position, the lumbar multifidus. There's thoracic multifidus as well, and cervical. The lumbar multifidus holds the spine in that nice hollow of the back. If everyone understands the word neutral spine, it's not dead straight. When we look at people's spine, the normal curvature is a nice, gentle, smooth lordosis is the term, and then we have a thoracic kyphosis and then a cervical lordosis. So that's what the goal of multifidus is, and the multifidus also resists subluxation or a translation. So it stops one bone slipping forward on the other, like that. Okay, it stops translation. So the one movement that is required to be perfect in is what we call neutral spine hip hinge. So hip-centric rotation as opposed to lumbar-centric rotation. So rotate through your hip joints when you bend, maintain a neutral spine position, activate your posterior kinetic chain, do not load your knees, and do not exceed the range of motion that starts to breach those aforementioned movement points of performance. So that's 5 movement points of performance that I've just mentioned there on paper. But when you actually engage in functional training, those 5 movement points of performance become a experienced reality, and I can feel my body regaining stability. Okay? That needs to be taught. That needs to be taught by an expert functional movement therapist, and we created that expertise in 2015. And that's one of the problems. Michelle was asking, if I go to see the chiropractor, is that good? Well, it is good if the chiropractor transfers those skills of movement to you. Okay? That's the key. And then you can recondition your multifidus, restore stability, and then you're sort of 90% of the way there.
Okay, now a couple of people have asked whether you are prepared to comment on liability, and I know that you do, so there's that answer. But the last question for today is fusion surgery appropriate treatment for a disc protrusion?
Okay, good question. So we treat the patient, we don't treat the X-ray, or we don't treat the MRI. A disc protrusion may be completely asymptomatic. Right? So therefore, of course not. We can't make you better than asymptomatic. A disc protrusion may be symptomatic, and the symptoms may be terrible neuropathic pain. Okay, so that means the disc protrusion is rubbing on a nerve and causing severe pain shooting down the leg. And if that is unrelenting and you've gone through maximum non-surgical interventions, supervised by someone who understands the pros and cons of surgery, then the correct operation may be simply a neural decompression procedure, which is not fusion. If you have instability associated with your disc protrusion, then a fusion is a consideration. Okay, because fusion only has the role of restoring stability. That is the only purpose of a fusion, stabilizing the motion segment.
Lovely. I speak for everyone here I know when I say that has been absolutely insightful, and I could sit and listen to you and ask you questions for the rest of the afternoon. This has been really terrific. Dr. Johnson, I thank you so much for your time today, and thank you everybody for joining us. You will be able to access this recording. It will be emailed to you within a day, but you can always watch it again from our YouTube channel. Thank you so much, everybody, and go and have a great rest of the day.
Thanks, everyone. Bye-bye.
Thanks, David. That was awesome. And stop recording.